Welcome back to the deep dive. I want to start today with a specific scenario. I want you to imagine you are a surgeon.
Okay.
You've scrubbed in, the lights are bright, you've got the scalpel in your hand, and you are staring at a patch of skin about, I don't know, 3 inches square, right on the side of a patient's face, just in front of the ear.
The parotid region.
The parotid region. Now, to the untrained eye or even to a generalist, this looks like a straightforward soft tissue surgery. There's a lump, you take the lump out, you stitch them up, simple geometry. But looking through the source material we have today, this really dense surgeon-oriented guide to clinical anatomy that seems like simple is, well, it's the absolute last word anyone should use to describe this.
Absolutely. I mean, not even close. If abdominal surgery is like driving on a highway, parotid surgery is like driving through a minefield.
Wow.
In the dark. Without headlights.
That is a terrifying image.
It's the truth, though. Look, the parotid gland itself, it's boring. It really is. It's a saliva factory. It's just this wedge of glandular tissue that makes spit. If that were the only thing there, this would be a procedure you could, do in your sleep.
Right.
But the problem isn't the gland. The problem is the tenants that live inside the building.
The convergence zone. That's the phrase from the source.
Exactly. This tiny area is a biological intersection, a grand central station of anatomy. You have major arteries pumping blood up towards the brain. You have veins draining the face. You have lymph nodes. But above all else, you have what surgeons sometimes call the million-dollar nerve.
The facial nerve.
Cranial nerve 7. The wire that controls every single expression you're capable of making.
Everything.
Smiling, frowning, closing your eyes, raising your eyebrows, blowing a kiss. It all runs directly through the center of this gland.
And that's the stakes, right? I was reading through the complications section of the notes, and it's heavy stuff.
Yeah.
We aren't talking about a bad scar.
No, not at all.
We're talking about a patient waking up and not being able to close their eye. Or not being able to smile at their daughter's wedding.
It is catastrophic. I mean, truly, it's an identity-altering injury. And the tricky part, the part we're going to dive into today, is that the nerve isn't just near the gland. It's inside it. It branches through it like a spider web.
So you can't just go around it.
You can't. You have to go through it. So our mission for this deep dive is to take that surgeon's map and really decode it. We want to understand how you navigate a scalpel through a spider web without breaking the threads.
I love that image. So we've got the stakes. Let's back up and look at the origin story, because the notes start with embryology. And usually when I see embryology, I admit, my eyes glaze over a bit. It feels like ancient history. It's like, why do I need to know this?
A lot of medical students feel the exact same way. It feels academic.
But here, the source makes this really compelling argument that the embryology is actually a cheat code. It's the loophole that makes the surgery even possible.
It is. It's the fundamental why behind the anatomy. If you don't understand the origin, you can't find the plane. It's that simple.
So break it down for us. How does this gland form, and why does it end up tangled with a nerve? Is it just bad luck?
It's not luck. It's all about timing. So go back to when you were an embryo, about 6 weeks old. The parotid gland starts as a little bud inside your mouth.
Okay.
Specifically, it's an ectodermal invagination.
Which is a fancy way of saying the lining of your cheek starts folding outward.
Exactly that. It grows from the mouth backward toward the ear. It's expanding like a balloon being blown up into the tissue space. Now, at the same time, but in a total different part of the neighborhood, the second branchial arch, the facial nerve is developing. And it starts moving forward.
So you have the gland moving back and the nerve moving forward.
Two strangers in the night.
And they're on a collision course.
And they crash. They collide. Now, here's the critical part. This is the aha moment. In most parts of the body, when tissues collide like this early on, they fuse. They become a mashup. The cells intermingle.
Like mixing two colors of Play-Doh, you can't really separate them again?
Right. You get green. But here, something lucky happens. Because the nerve arrives slightly late in the development of the gland folds around it. It envelops it. It doesn't absorb it.
This is the sandwich concept mentioned in the source.
This is a classic teaching analogy. It's a great way to picture it. Imagine you have 2 layers of dough. You lay a wire on the first layer. That's your deep lobe of the gland.
Okay.
And you slap the second layer of dough, the superficial lobe, on top of the wire.
So the wire is inside the loaf.
It's inside the loaf, physically. If you bake that bread, it would look like one solid piece. But the wire is not baked into the dough itself. It's sitting in a seam, a natural separation between the layers.
And that seam has a name.
Patey's plane. Named after David Patey, a British surgeon who really popularized this concept in the mid-20th century.
And this is the key. Because the nerve is in a plane, you can separate the layers. Is that the idea?
That's the entire idea. If the nerve were fused, if it were mixed in like the Play-Doh, you'd have to cut through nerve to get a tumor out. There'd be no other way. But because of this embryological distinctness, you can peel the gland off the nerve, you can split the sandwich, remove the bread, and leave the wire completely intact.
That's wild. It's like the body left a maintenance hatch open for us.
It essentially did, but, and here's the big caveat, the plane isn't always easy to find. It's not, a big open space.
Right, there's no dotted line saying cut here.
Not at all. The layers are pressed together tight by fascia. You have to create the space. You have to find the seam and then develop it.
Which brings us to the visual map. Before the surgeon even makes a cut, they have to know where the boundaries are. The notes call this the surgical box. And I want to actually build this box for the listener.
Let's do it. It's a great exercise.
Okay, so if I'm a surgeon and I'm looking at the side of someone's face, what are my hard stops? What are the walls I cannot cross?
Okay, visualize the side of your face. Everyone listening can do this.
Yeah.
Let's start with the roof. The superior boundary. That is the zygomatic arch.
Or the cheekbone.
Right, that horizontal bone running from your cheek to your ear.
Right.
That is the northern border. You rarely go above that for a standard parotidectomy.
Okay, so cheekbone on top. What's the floor?
The angle of the mandible. The sharp corner of your jaw where it turns up toward your ear.
Got it. I can feel that.
Okay, so now the front wall, the anterior border, is the posterior border of the ramus of the mandible. Basically, follow your jawbone up towards your ear, and the big muscle there, the masseter muscle, you clench with.
So the back edge of the jawbone itself.
Correct. And the back wall.
The back of the box.
Two things. The external auditory canal, your ear hole, essentially, and the mastoid process.
Yeah.
That's that hard, bony bump you can feel right behind your earlobe.
Oh, yeah, definitely.
That's a critical landmark.
So inside this box, cheekbone, jaw angle, jaw ramus, mastoid, sits the parotid.
Correct. It fills that space completely. It's wedged in there.
But the notes mention a specific shape. They call it wedge-shaped.
It is.
Yeah.
Think of a slice of pie that's been sort of shoved into that space between the jaw and the mastoid.
Okay.
The thick crust of the pie is at the back, pressed up against your ear and mastoid. And the pointy tip of the pie tapers out onto your cheek towards your mouth.
Now, speaking of the shape, there's this one diagnostic tip in the source that I absolutely loved. It's the ear lobule clue. I highlighted this because it feels like a Sherlock Holmes moment.
It is one of the most reliable physical signs in all of head and neck surgery. It's a classic.
The source says the ear lobule, the soft fatty part, sits directly on top of the tail of the gland.
Yes. The cauda, the tail of the parotid.
So walk me through the mechanics. Why does the earlobe move? Why doesn't the cheek just swell up?
Well, it's all about leverage. The tail of the parotid wraps around the angle of the mandible, is tucked in there really tight, and sitting right on top of it like a blanket is the ear lobule. Now, imagine you have a balloon under a tent. If you inflate that balloon, what happens to the tent pole?
It goes up.
It goes up. Since the tail of the gland is directly under the earlobe, if the gland swells, say, from a tumor or an infection, it has nowhere to go but up, and it pushes the earlobe up and out.
It acts like a lever.
Exactly. It literally props the earlobe up. So if a patient walks into your clinic and you see their earlobe flaring outward, looking like it's kind of floating away from their head,
You know immediately.
you know it is almost 100% a parotid mass. It's a dead giveaway. I mean, if it were a lymph node in the neck, it would be lower. If it were a skin cyst, it would look different. But that specific lifting of the lobule, that's the parotid saying, I'm here.
I love that. You don't even need to touch the patient yet to have a really strong hypothesis.
That's the art of clinical anatomy. It's reading the signs.
Okay, so we know where it is. We know the shape. Now we have to cut. And the first thing we hit isn't the gland. It's the wrapper, the fortress, the parotid capsule.
The capsule. And this isn't just a thin piece of cling film like you'd find around other organs. The source describes it as unyielding.
Derived from the investing layer of deep cervical fascia. That sounds serious.
It is. That's anatomy speak for really tough connective tissue. This fascia wraps all the muscles in your neck like a girdle, and then when it gets to the parotid, it splits and encases the entire gland.
And the fact that it's unyielding explains the pain, right? I found this fascinating, the specific type of pain that comes with parotid issues.
Though the pain is distinct. If you've ever had the mumps or a bad bacterial parotitis, you know this pain. It is excruciating.
Why is it worse than, say, a swollen lymph node?
It's pure physics. The gland is inflamed, it's filling with fluid or pus. It wants to swell, it wants to double in size. But the capsule says no, it does not stretch.
So the pressure goes inward.
It's a pressure cooker.
Yeah.
The tension rises immensely because the volume is constrained. That's why patients with acute parotitis are in just agony. The tension is trapped inside that leather bag. Now, surgically, this capsule presents what the source calls the first danger. And the notes have this in bold red letters. Never blindly breach the capsule.
This is rule number 1. If you break this rule, you can end the career of a violinist or a news anchor in a split second.
Why? What happens if you just poke through it?
You have to remember the geography. We just talked about the sandwich. The facial nerve is deep to the capsule, but in some people, especially thin people or elderly patients with atrophy, there is almost no glandular tissue acting as a buffer.
So there's no bread on top.
Very little. The wire can be right under the crust of the loaf. So if you take your scissors and just pop through that capsule without looking, you might snip a branch of the nerve before you've even started the real dissection.
Oh my.
You're blind at that moment. You haven't identified anything.
So you have to peel the orange, not stab it.
Precisely. You lift the capsule, you incise it carefully under direct vision, and you look. Always look before you leap. Let's talk about what lies beneath, because there is a deep zone. And this part of the notes, I have to say, it gave me the creeps. The iceberg effect.
This is where the anatomy gets really deceptive.
We tend to think of tumors as things that stick out. A lump on the cheek, right? But the source says some parotid tumors don't stick out at all. They stick in.
Right. Remember the box we built? The outer walls are bone and that thick, unyielding fascia. It's a fortress on the outside. But the inside wall, the medial wall that's facing your throat, is much thinner.
It's the weak point.
It's the path of least resistance. Physics takes the easy road. If a tumor starts in the deep part of the gland, it can't push out through the jawbone, so it pushes inward. It grows into what's called the parapharyngeal space.
So the patient comes in, and their face looks relatively normal.
Face looks fine, no lump on the cheek, but maybe they complain of a lump in their throat, or their voice sounds funny, kind of muffled.
Okay.
You look in their mouth, and the tonsil on that side is being pushed all the way over to the uvula.
The medial bulge.
That's the sign. And for a surgeon, that is a red alert. It means this is not a routine surface surgery. This is a deep dive. The bulk of the tumor is hidden.
Talk about that neighborhood, the medial relations. Because it's not just empty space back there.
Far from it. It's the danger zone. It's the bad neighborhood of the head and neck. Deep to the parotid, you have the styloid apparatus. That's the styloid process and the muscles attached to it. But just deep to that, you have the internal carotid artery.
The main bloodline to the brain.
Yeah. You have the internal jugular vein. And you have the last 4 cranial nerves, 9, 10, 11, and 12.
Glossopharyngeal, vagus, accessory, hypoglossal.
All of them, controlling swallowing, your heart rate, shoulder movement, and tongue movement. All of them are bundled together in that tiny space. A deep lobe tumor is sitting right on top of them.
So when you are removing that iceberg, you are working millimeters away from causing a stroke or major nerve paralysis that has nothing to do with the face.
Correct. It reinforces that idea of the map. You can't just hack away. You have to know what is behind the wall you're working on.
Okay, let's get back to the star of the show, the facial nerve. We talked about the sandwich and the plane, but the notes bring up a really important correction about the concept of lobes.
Yes. This is a pet peeve of anatomists, and it's a critical point for surgeons.
The source says lobes are a surgical concept, not an anatomical one. What does that mean?
It means if you take a parotid gland out of a cadaver and put it on a table, there is no natural separation. It's one blob of tissue. There is no visible superficial lobe and deep lobe.
But surgeons use those terms all the time. A superficial parotidectomy is a standard operation.
We do, but we define them by the nerve. The superficial lobe is just a shorthand for everything that sits on top of, or lateral to, the nerve. The deep lobe is everything that sits underneath or medial to the nerve.
So the nerve defines the lobes don't define the nerve.
Exactly. The nerve is the reference point, the prime meridian. And the space between them, Patey's plane, is the space we create by dissecting along the nerve.
And there is a golden rule of dissection mentioned here. It sounds like something a master carpenter would say. Never pull the gland away from the nerve.
It sounds counterintuitive, right? You want to take the gland out, so surely you grab and pull.
That's what I would assume. Get it out of the way.
But if you pull the gland, and the gland has all these tiny nerve branches running through it, what happens to the nerve?
You stretch it.
You stretch it. And the facial nerve is incredibly sensitive to traction. Traction injury is one of the most common causes of temporary facial paralysis after surgery. Even if you don't cut it, just stretching it can stun it for weeks or even months.
So what is the correct technique?
You hold the nerve steady, or rather, you don't put tension on it. Use instruments to gently spread the tissue. And you dissect the nerve away from the gland. You gently peel the tissue back, always keeping the nerve in sight and relaxed.
You are active on the tumor, passive on the nerve.
That is the mantra. That is the entire philosophy.
But all of this relies on one thing. You have to find the nerve first. And this segment of the notes was, for me, the most dramatic, the hunt.
It is the moment of truth in the OR. The whole room gets quiet.
The source says the priority is identifying the main trunk first before chasing any branches. Why is that? Why not just find a small branch and follow it back to the source?
You can do that. It's called retrograde dissection, and sometimes in a difficult case you have to, but it's much riskier. The branches are tiny, they're fragile, they weave in and out of tissue. It's very easy to get lost or injure one.
Right.
The trunk is the tree. It's thick, it's consistent, it has a predictable location. You always want to find the tree trunk, then follow the limbs out. It's the safest way.
So we've opened the skin. We are looking for the trunk, but we can't see it. It's buried in tissue. The source emphasizes triangulation.
Right. You are navigating in a sea of pink and yellow tissue. Everything looks like everything else. You need fixed points. You need lighthouses to guide you.
Let's walk through the 3 key landmarks, and I want to know what they actually feel like to the surgeon. First, the tragal pointer.
This is a favorite. Everyone learns this one. The tragus is that little cartilage flap in front of your ear canal.
Touching it right now.
If you dissect down, the cartilage of the ear canal forms a sharp, distinct point at its deep end. It literally points inward like a little finger.
So you can feel that sharp edge with your instrument.
Oh yeah, you can feel it with a hemostat. It's a very distinct tink. And the rule is, the facial nerve trunk lies approximately 1 centimeter deep and slightly inferior to this pointer.
So find the pointer, go 1 centimeter deeper and a little bit down, and there it is.
Usually. But 1 centimeter is a very dangerous assumption. In a big, swollen, inflamed gland, it might be 2 centimeters. In a baby, it's 3 millimeters. So you can't rely on the pointer alone. It's a guide, not a guarantee.
So you look for the second lighthouse, the posterior belly of the digastric.
This is a muscle, a beautiful strap-like muscle. It attaches to the mastoid area behind the ear, and it runs down into the neck.
What's the relationship to the nerve?
The facial nerve is always superior to this muscle. Always. The muscle acts as a floor. If you find the muscle, you know the nerve is just above it. It gives you a safety net. You know not to dig below that muscle.
And finally, the third landmark. The notes call it the bedrock, the tympanomastoid suture.
This is the most reliable landmark because it is bone. Bone doesn't move. Muscles shift, cartilage can bend, but bone is truth.
What is it exactly? What am I feeling for?
It's a suture line, a tiny groove between the tympanic plate, which is the ear bone, and the mastoid process. You can actually feel it with your fingernail or a delicate instrument. And the nerve exits the skull from the stylomastoid foramen, just slightly anterior to this line.
So the surgeon triangulates. Pointer from above, muscle from below, suture from behind, and where those lines intersect.
Boom. There lies the facial nerve trunk. It usually appears as a beautiful, white, glistening cord about the size of a matchstick.
And once you see it, what's that feeling?
Your heart rate drops about 10 beats per minute. The tension in the room just melts because now you know where the enemy is, or rather, where the VIP is. You have your anchor.
But you aren't done, not by a long shot, because then the nerve enters the gland and it explodes into branches. The branching matrix.
The pes inserinus.
Which translates to?
The goose's foot. Because that's what it looks like.
Yeah.
The trunk comes in, and then it splits into 2 main divisions. The temporofacial going up and the cervicofacial going down, and then those fan out into the 5 terminal branches.
I want to go through these 5 branches, but I don't just want to list them. I want to talk about the stakes. The source details exactly what happens functionally if you cut each one.
Let's do it. This is the practical application.
Okay, top branch, the temporal branch. Where's it going?
It travels up, across the zygomatic arch, to the forehead. It innervates the frontalis muscle.
So if you injure this, the patient loses the ability to
wrinkle their forehead or raise their eyebrow on that side.
So they have a perpetually smooth brow, like a free Botox injection.
Yes, but it's not a good thing. More importantly, the brow droops. It sags down, and in older patients especially, that can impair their superior vision because the skin just hangs over the eyelid.
Branch number 2, the zygomatic branch.
This goes to the eye muscles, specifically the orbicularis oculi. This is the danger branch. This is the one that keeps surgeons up at night
Why is it the big one?
because it controls eye closure. If you paralyze this branch, the patient cannot close their eye.
Which sounds annoying, but it's much worse than annoying, right?
It's medically dangerous. We blink to lubricate our eyes to keep the cornea healthy. You can't blink, you can't close your eye when you sleep at night. The cornea dries out. You get something called exposure keratitis. You can get ulcers. You can literally go blind in that eye.
Wow. So preserving this branch is about preserving sight.
Absolutely. It is a non-negotiable part of the operation.
Okay. Branch number 3, the buccal branch.
Goes to the cheek and the upper lip. It controls the tone of the cheek, the bustinator muscle.
What happens if it's cut?
The cheek becomes flaccid. It gets floppy. So when the patient eats, food gets stuck in the vestibule. That's the pocket between the teeth and the cheek.
Oh, that sounds frustrating.
It is. They have to constantly use their finger or their tongue to push the food back onto their teeth to chew it. It's messy. It affects their quality of life, but it's not as devastating as the eye injury.
Okay. Branch number 4, the marginal mandibular branch.
Ah, yes. The source calls this the most commonly injured branch
Why? Why is it the most common victim?
because of its path. It's a bit of a wanderer. It loops down low. In about 20% of people, it actually dips below the jawline into the neck before curving back up to the corner of the mouth.
So it leaves the safety of the box.
Exactly. So if a surgeon is working in the upper neck or removing the tail of the gland and they're not careful, they can snag it easily because they don't expect it to be that low.
And the result, what does that look like?
It paralyzes the depressor muscles of the lip. So the patient gets an asymmetrical smile. When they smile or try to show their teeth, the affected side doesn't move down and out. It stays up. It creates a very noticeable crooked smile.
Which is socially very difficult for people.
Very. We look at mouths when we talk. It's incredibly hard to hide.
And finally, the 5th branch, the cervical branch.
Travels straight down to the platysma muscle in the neck.
And if you cut it,
Honestly. Usually nothing that the patient even notices. Maybe some subtle weakness in the neck skin when they grimace. But clinically, it's often considered the expendable branch if you, say, need a piece of nerve for a graft somewhere else.
so to recap, temporal is forehead, zygomatic is the eye, buccal is the cheek, marginal mandibular is the smile, and cervical is the neck.
That's the hand on the face. That's the mnemonic.
Now the nerve is the VIP, but it's not alone in the matrix. We have the supporting cast, the veins and arteries.
There's the plumbing. And the plumbing has rules.
And there's a very specific rule about depth here that the source emphasizes, the NVA order.
Yes. This is a classic exam question for residents, but it's also a life-saving heuristic in the operating room. From superficial to deep, the order is always nerve, vein, artery.
NVA.
So closest to the surface, most lateral, is the facial nerve. Deeper to that is the retromandibular vein. And deepest of all, buried near the deep lobe, is the external carotid artery.
The source has a surgical warning regarding this order, and it says unexpected venous bleeding is a massive red flag.
It is the stop everything you are doing sign. The alarms go off in your head.
Walk us through the logic. Why is blue blood so bad in this context?
Okay, so imagine you are dissecting. You're trying to find the nerve. You think you are still superficial, still in the superficial lobe. Suddenly your scissors hit a big vein and it starts bleeding briskly.
Okay.
That vein is the retromandibular vein. And where does the vein live according to our rule?
Deep to the nerve.
Deep to the nerve. So if you're hitting the vein, it means you have already passed the plane of the facial nerve without seeing it. It means you are too deep. You missed it. And if you missed it, you might be working underneath it. You might be retracting it blindly, stretching it, or worse, you might have cut right through it to get to the vein without even realizing it.
That is a stomach-dropping realization to have mid-surgery.
It is. So the rule is, if you see the vein and you haven't seen the nerve yet, you stop. You do not proceed. You pack it, you get control of the bleeding, you back out, and you find the nerve more laterally. You reset.
Talk to us about the arteries for a second. The external carotid artery tunnels right through the gland.
It does. It comes up in the neck, enters the deep aspect of the gland, and then gives off its two terminal branches right inside the gland substance, the maxillary artery and the superficial temporal artery.
So if you are doing a total parotidectomy, taking out the whole gland, you are dissecting right on top of a major high-pressure artery.
Yes. And bleeding from there is very difficult to control because the artery can retract up towards the base of the skull into bony structures. It's not for the faint of heart.
We've covered the motor nerves, the veins, the arteries, But there are sensory nerves, too. And one of them leads to this really strange condition mentioned in the source, Frey's syndrome.
Yes. Gustatory sweating. The party trick of parotid surgery.
This falls under the category of weird science. I read this and I just thought, the body is amazing, but sometimes it is remarkably stupid.
It's not stupid, it's just
Well,
confused. It's an error in rewiring, like a faulty electrical job.
Walk us through the mechanism here. What goes wrong?
Okay, so it involves the auriculotemporal nerve. This is mainly a sensory nerve for the skin of your temple, but it also carries these special fibers called secretomotor fibers.
Secretomotor means
Secrete and motor. They are the electrical signals from the brain that tell the parotid gland, hey, we're eating. Time to make saliva.
okay. Brain says food, nerve says spit. Simple enough.
Right. Now, during the surgery, you are removing the parotid gland. To do that, you have to cut those tiny secretomotor nerve fibers because they go into the gland that you are taking out.
So the wires are cut and they're just hanging loose in the surgical bed.
Correct. Now, the surgery is over. You sew the skin flat back down over the empty space. The body starts to heal. And those cut nerves, like all nerves, they try to grow back. They're looking for their target.
But the target, the salivary gland, is gone.
It's in a pathology jar on a shelf somewhere. So the nerves grow outward, searching. And what do they run into?
The skin.
The sweat glands in the skin of the cheek.
And they just decide, close enough.
Basically, they hook up to the sweat glands. It's called aberrant regeneration.
Yeah.
The wires get crossed.
So the wires meant for saliva are now plugged into the sweat glands.
Exactly. It's a classic cross-wiring error.
So what happens when the patient eats a sandwich 3 months later?
The brain sends the signal. Food. Salivate. The signal travels down the auriculotemporal nerve, but instead of triggering saliva production, it triggers the sweat glands. And the patient starts sweating profusely over their cheek and temple.
That is just bizarre.
It can be very socially distressing. Imagine sitting on a date, you bite into a lemon tart, and suddenly the side of your face is just dripping wet.
Can this be prevented? The source mentions some techniques.
It's difficult to prevent 100% of the time, but surgeons try to place a barrier. After removing the gland, they might rotate a thin muscle flap or place a piece of fascia like a biologic sheet over the gland bed before closing the skin.
To block the nerves from reaching the skin.
Exactly. It's like putting insulation tape over the live wire so they can't touch the skin and make a new, wrong connection.
That makes perfect sense. Before we wrap up the anatomy, we need to touch on one last system, the lymphatics. This was a surprise to me.
We can't ignore this.
Yeah.
The parotid isn't just a salivary gland, it's also a lymph node station.
There are lymph nodes inside the gland.
Yes, intraglandular nodes. This is pretty unique. Most salivary glands don't have lymph nodes inside them. The parotid does.
What's the implication for the surgeon? Why does that matter?
It changes the cancer game completely. It means that a skin cancer on the face, like a melanoma on the temple or a squamous cell carcinoma on the ear, can spread to the parotid gland first. It's the first station.
Oh, wow. So you could be operating on the parotid not for a primary parotid problem, but for a skin cancer problem that has spread.
Exactly. A patient might come in with a lump in the parotid, and it turns out to be a metastasis from a skin cancer they had removed 2 years ago and thought was cured.
So surgeons have to be detectives, looking at the whole head and neck.
Always. You have to check the history, check the skin, and conversely, if you were treating a primary parotid cancer, you have to check the neck nodes, because the drainage from the parotid goes down into the neck. It's all connected.
We've covered a massive amount of ground today. The embryology loophole, the surgical box, the capsule pain, the iceberg effect, Parotids plane, the triangular search for the nerve, the branching matrix, the NVA depth warning, and the cross-wiring of Frey's syndrome.
It's a very comprehensive map.
The source concludes with final surgical pearls, a summary of the mindset required for this surgery. I want to just run through these as our closing takeaways.
These are the rules to live by in this part of the body.
Pearl number 1. Think in layers and planes, not masses.
Right. Don't just see a lump, see the fascial sheets that surround it. The surgery is about developing those sheets, not just cutting out a ball of tissue.
Pearl number 2. Respect Parotids plane.
That is the seam. That is the gift from embryology. Find it, stay in it, and the nerve will be safe.
Pearl number 3. Identify the nerve trunk first.
Don't chase branches blindly. Find the tree trunk using your reliable bony landmarks. Anchor yourself.
And pearl number 4. Avoid traction.
Be gentle. Dissect the tissue away from the nerve. Don't pull the nerve away from the tissue. The nerve hates to be stretched.
It really seems like the big takeaway here is that parotid surgery is the ultimate test of anatomical knowledge. It's not about how fast you can cut. It's about knowing exactly where not to cut.
Absolutely. There's an old surgical saying, the eyes cannot see what the mind does not know. In the parotid, if you don't know the anatomy, you are functionally blind. If you know the map, you can navigate the minefield safely.
It really makes you appreciate the incredible complexity hidden right under our skin. You know, as we close out, that concept of Patey's plane really sticks with me.
How so?
It's just this idea that even in a tangled, complex mess like the parotid gland, there is a natural seam, a plane of separation that was put there by the way we developed millions of years ago. And the safest way through isn't to force a path, not to cut through the problem, but to find the path that's already there.
That is a very profound way to look at it. The seams are usually the safest route in biology. We fight against anatomy at our peril. We work with it to heal.
A little philosophical thought to end on. Next time you feel your jawline, you can visualize that wedge, the fortress capsule, and the incredible network of nerves firing away inside it so you can smile at your neighbor.
And protect that ear lobule. Don't let anything lift it.
Exactly. Thanks for listening to The Deep Dive. We'll see you next time.